Hello, everybody, and welcome to the Student Success Session on Stroke and Acute Intracranial Problems. And when we talk about any kind of intracranial problem, whether it's a hemorrhagic stroke or an ischemic stroke, we go back to our basic anatomy of the substances that are inside the skull. We know that the skull is a bony box, is how I describe it. And inside the skull, there are three items. That's the brain, which takes up the majority of the space within the skull, and then the CSF, or cerebrospinal fluid, and the blood. And all of these things must maintain their amount of space that they must occupy. And because the skull is an enclosed item, these three things are inside this enclosed space, and therefore pressure is generated. And of course, that's known as the intracranial pressure, with the normal being 5 to 15. Now, the other thing that you need to recognize is that the brain must have oxygen, and the brain must have oxygen or cannot do without oxygen for a very, very short time. Anywhere from 2 to 4 minutes is what it's deemed, or 4 to 6 minutes. But regardless, the brain has to have oxygen. And oxygen delivery to the brain is known as cerebral perfusion. And so you, as the nurse, for any patient that arrives with intracranial problems, must think about, is there oxygen getting to the brain cells? Because if there's not, then you know that those brain cells can become ischemic, which is less oxygen than normal, and that they can ultimately die. So how do you determine whether there is enough cerebral perfusion or enough oxygenation to the brain? Well, you calculate the MAP, the mean arterial pressure, and you subtract the ICP, or intracranial pressure, from the MAP, and that will give you the CPP. The normal CPP in the critical care course is deemed to be 70 to 100. Now, if you're a neuro queen or king and you know a lot about this topic, the books frequently list 60 to 100, but this is all about the test to a certain extent. And in Dr. Reed's rules, the CPP should not be less than 70, so it has to be 70 or greater. Now, there's various consequences that can occur when it's less than 70, but really for you, what you need to know is the minimum number that's acceptable for your patient is a CPP value of 70. So anything less than that is not good. And because the formula for cerebral perfusion pressure is MAP minus ICP, that tells you that the ingredients or the individual components of this formula are going to be the blood pressure and the ICP. So when we look at the blood pressure, you can see you're given a whole value at 120 over 80, systolic over diastolic. And you know that the MAP normally can be calculated by the automated blood pressure machines, but not on a critical care course. So I would tell you, and I would tell you 2 or 3 times, make sure you calculate the MAP for every blood pressure. So when we do a MAP calculation for 120 over 80, and then we subtract the ICP from that MAP, we get that the CPP of a patient could be 78.33. So that fits the criteria of all is good. And then we look at the next value, and we have a blood pressure of 80 over 40 and an ICP value that is still normal, and it is 15. And when we calculate the MAP and subtract the ICP from that MAP, we can see that our CPP with just a blood pressure change will markedly decrease. And then when we look at the next value of 120 over 70 and a markedly elevated intracranial pressure, we see that the CPP calculation is, again, poor. It is less than 70. So, okay, great. We can do math together, so that's fabulous. How is this helpful? Well, because what happens, or what you have to relate, is that your patient's perfusion is going to greatly determine or be dependent on their blood pressure and their intracranial pressure. Because if you have a normal intracranial pressure but a very low blood pressure, that's going to create a bad brain perfusion. As well as if you have a normal blood pressure but a markedly elevated ICP is going to create a bad CPP. Am I droning on? Yeah, I am. But what I want to for you to get is it doesn't matter what the question is asking you. If you're given a blood pressure value, you better calculate the MAP. And if you're given an ICP value, you better calculate the CPP. So let's look at this. So if the CPP is less than 70, less than the required amount, what are the causes? Well, we already know that the two ingredients of a CPP are blood pressure and ICP. So if the blood pressure is too low, which there are multiple causes of that, and we're really not going to get involved in that now. We will on exam 2, but not on exam 1, then we've got to fix the blood pressure. So for instance, in that example where the blood pressure was low and the ICP was normal, then we're going to have to, and it comes out that the CPP is low, then the physician must be contacted because you've got to do something about the blood pressure, and it's probably going to take some kind of drug fix. So again, I want to give you more rules. I already told you that the CPP has to be a minimum of 70 or greater. There really isn't a high-end value of it that you have to worry about. It's really you got to at least have a 70. But yes, there's some values for blood pressure that you have to know. And you need to write these down so you always remember it. Dr. Reed expects or requires that patients have a systolic blood pressure at least 90 or it can be better. And then the patient needs a MAP, a mean arterial pressure, of 70 or better. And these are Reed's rules. CPP of 70 or better, MAP of 70 or better, and the systolic blood pressure of 90 or better. Now, what's another cause of cerebral perfusion imbalance? Well, of course, we know the other ingredient is the intracranial pressure. And if the intracranial pressure is off, or there's an imbalance in the intracranial pressure, it can actually occur because of several different reasons. Well, actually, around 3, because we know that inside the head, there's the brain. So if the brain was swollen or there was cerebral edema, then the brain would take up more space than it's supposed to in our balance inside the skull, and therefore the intracranial pressure can go up. So what would be some reasons that the cerebral edema would occur? Well, we know for sure that when oxygen is not being delivered, then the cells convert to anaerobic metabolism, but they can't because the brain cells can't do that. So as soon as the O2 is lacking, then the brain cells will ultimately become edematous. Or if there is some kind of traumatic injury to the brain, or if there's an infection to the brain, drowning would cause lack of O2, and so that would cause edema. So there are many, 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 many instances. Now, of course, we're talking about the critical care course and exam 1 item, and on exam 1, you have intracranial problems such as hemorrhage, intracranial hemorrhage, or a hemorrhagic stroke, or subarachnoid hemorrhage, and you have an ischemic problems such as a brain attack. So any of these things are going to cause cerebral edema. Then again, too much blood, and this could be bleeding into the brain. So your subarachnoid hemorrhage can actually cause 2 instances where the intracranial pressure can elevate, and that's from edema, from irritation, from the blood sitting on the brain cell, and also because there's too much blood inside the brain or inside the skull, taking up too much space. Cerebrospinal fluid can be increased for various and sundry pathologic reasons, and this is really mentioned in the pediatrics course, and we don't address it in the critical care course. Therefore, and for your nursing considerations for any patient with an intracranial problem, so this is going to relate to exam 1 and exam 3, you are going to have to determine what is happening. Is the intracranial pressure going up because of the problem, the intracranial problem of the patient? Or how do I fix the intracranial? Because if I have to manage the intracranial pressure, then I have got to figure out how to ensure that either it doesn't go up, or once it has increased, then I have to use measures that will have it come down. And I've put this little alarm bell right here because these are what Dr. Reed's going to test you on. So these are the important considerations that you have to do, and you're going to learn how to do this as we go through this review session. This slide is one that's been posted in the stroke and intracranial content review, and this is something you have to know like the back of your head. I would like to point out that the level of consciousness changes occur very early, that these three things put together are known as Cushing triad. Ocular pupil signs, I've addressed that, where the pupils are either fixed and dilated, fixed and constricted, or just plain uneven. And then, of course, posturing. And then these are the interventions that are used to ensure that the ICP doesn't go up, or if it has gone up, that the ICP doesn't rise even further. So we look at the head of the bed. Should never be elevated higher than 60. It should be at 30 to 45. And of course, yeah, I love to have these exceptions to the rule that the head of the bed should not be elevated if every time you elevate the head of the bed that drops the blood pressure. That's kind of your one exception. Straight, we want to keep the neck straight to promote venous return out of the head because that'll reduce the volume that's in the head. We want to keep the systolic blood pressure. I've got 100 there. That's probably a semi-normal, but remember Dr. Reed's rule, it has to be 90 or above. Space out stressful activities. And I do want to talk about straight. We do say keep the neck straight, but also I want to make sure you understand that if you have your patient, and let's say you're cleaning up the patient because they've been incontinent, a stool, or their urine, and when you lift up that leg up high to where so that you can, because you can't turn them for whatever reason, and you lift up that leg, remember that anytime you flex the hip, especially way up high, that will put pressure on the abdominal area, which is the other reason why you never lift the head of the bed over 60, and that will also increase the intracranial pressure. And then, of course, I've got the other 8 of ICP management here that were addressed earlier. But what I really want to relay to you is these are really key slides as far as testing material goes. So let's do some practical application of the information that you've already received from either the content delivery or from what I just mentioned. So we've got which of the following are the major sources of intracranial hypertension after a brain attack or intracranial bleed? You can pause the recording if you want to try and answer. I'm just going to keep going. So what is the answer? The answer is cerebral edema and expanding lesions. Now, a lot of times students will not quite understand what the question is asking because words are used that are somewhat confusing. And so when you look at this intracranial hypertension, what does that mean? Well, that means the ICP or intracranial pressure is elevated. That's all that means. That's just a fancy way of saying that. And when we look at the answer that cerebral edema, well, we understand that cerebral edema will cause that brain cell to swell and therefore it'll take up space. But what does it mean to be an expanding lesion? I want to relay to you that let's say that you twist your ankle, you know that there will be some swelling immediately after the injury, and of course there's some pain, but when you wake up the next morning, there's even more swelling. And so that's pretty much what you need to identify, is that anybody that has a problem with an intracranial problem, and they have a cerebral edema, day 1, there is edema, but by day 2, there's far more edema. And that's why the intracranial pressure can continue to go up and up and up. Now, we know that intracranial hypertension could be caused by hypervolemia, but really we're asking specifically which of the following are the major sources. And so I want to just point out to you that anytime you have a question, you have to understand that there will be answers that are listed that are correct, but they don't necessarily answer or correctly or are the best answer. And I know that's the annoyance about nursing questions, is because there are some good answers, but there's always a better or best answer, and that's the one you have to pick. And sometimes it's pretty hard to determine which one is the best answer. If you have any questions or you have some disputes or something that you disagree with, be sure and email me. So which problem can cause increased intracranial pressure? So let's look at the options here. We know what hypoxia is. That's a lack of oxygen at the tissue level. Hypocapnia is a fancy way of saying that there's less CO2 in the blood than normal. And then there's hypokalemia and dehydration. So which is the answer? Well, it's the one that's been changed to the red font. And so hypoxia can increase the intracranial pressure. So we look again at this is a lot related to pathophysiology. And whenever the cell is hypoxic, then the cell will not make ATP. And most of the ATP that's made is utilized for manning the sodium and potassium pump. And whenever there is less ATP, then sodium sneaks into the cell and the cell can disrupt or the cell membrane can break and then water will just flow in there. So you have to understand, again, you won't be asked about that long-winded patho part, but you have to understand that hypoxia will cause cellular or brain cellular swelling. Now, hypocapnia means low CO2, and it's actually the reverse. High CO2 will cause the brain cell or the blood volume in the head to increase. Here's what I mean. Whenever there's hypoxia as well as hypercapnia or high CO2 and low O2, these gases, when they're altered, will have an effect on the vasodilation of the cerebral blood vessel. So there will be a vasodilation of the cerebral blood vessel and therefore more blood in the head, which can cause an increase in intracranial pressure. So that is how O2 and CO2 affect the blood space or the blood vessels of the cerebrum. So the cerebellar blood vessels, they will vasodilate and vasoconstrict. And that's how the brain works, because if you stand on your head, then that's how your blood vessels can vasoconstrict so that all that blood won't flow down. Again, email me with questions. So which of the following is the best indicator of neurologic change? And hopefully this is one that's very easy for you to identify too. And always the answer in many different tests has been change in the level of consciousness. So that's answer C. And we know this to be true when you look at that slide that I told you was very important about rising ICP signs and symptoms, because we know that the first sign and symptom of rising ICP is a change in level of consciousness. And so that's why, because it occurs early, as soon as the ICP goes up, then the LOC can alter. A patient with an acute brain attack was restless during the night, and this morning she's exhibiting a diminished level of consciousness. Right pupil has become non-responsive to light, and there's an increase in the patient's systolic pressure, decrease in diastolic, and a slowing of her pulse. So what do these vital sign changes indicate? So I want you to know that these are the signs and symptoms of D. Cushing's triad. And you will be asked about Cushing's triad on exam 1, exam 3, and the final. And often it's not this simple, because this is very easy to identify that, you have a change in the blood pressure, you have a slowing of the pulse, you have a decreased level of consciousness. Sometimes you're asked in a very subtle way, but I always want you to think about the signs and symptoms of rising ICP, and especially Cushing's triad. It's really quite frequently on an exam. Possible interventions for increased intracranial pressure include any of the following except. So let's look at this and we go, okay, this is an except question, which means you have to pick what's known as the outlier or the one that doesn't fit. So when you play this backwards and you say, well, what things would decrease the intracranial pressure, you know that mannitol or Medicate would decrease intracranial pressure because it's an osmotic diuretic. We know that hyperventilation therapy will decrease intracranial pressure because whenever the CO2 is lower or decreased than normal, then the cerebral blood vessels will vasoconstrict. That means that there's less blood in the head, so the ICP has the potential to not raise or at least to to decrease or stay lower. And then drainage of CSF. Drainage of CSF is one of the evacuate. So essentially what I'm asking you about is all of the 8s of ICP management. The only answer choice that's the outlier, that's the one that doesn't fit, is that repositioning of the patient. And repositioning of the patient, turning the head so that it's not in alignment, bending the leg at the hip so that it's at a 90-degree angle. All of these things are actions or interventions that will cause the ICP to go up, and that's why that is the answer. When utilizing hyperventilation therapy, what is the physiologic rationale for the maintaining the CO2 between the value of 25 and 35? Recall that normal CO2 and again, normal CO2 is between 35 and 45. And I would also say to you, you cannot control CO2 unless the patient's on a ventilator. So what's the answer? What's the rationale for maintaining that CO2 while the patient's on a ventilator between 25 and 35? And the answer is answer D. Whenever there is a below normal CO2, that will cause vasoconstriction of the cerebral blood vessels. And that vasoconstriction of the cerebral blood vessel will decrease intracranial blood volume or decrease intracranial volume, which will allow the ICP to go down. The problem or the risk associated with decreasing the CO2 and causing cerebral vasoconstriction is that you may reduce blood flow in general. And if you reduce blood flow in general to an area that may not be getting the best of perfusion, then you do have a risk of causing cerebral ischemia. So that's why that value of 25 to 35 is kept or maintained, because it has to be just right, very particular to ensure the safety of the patient and that we don't cause harm and that we're actually giving them the benefit. A 78-year-old man is admitted to the critical care unit with an intracranial problem. The Glasgow Coma Scale is 5, and there's your vital signs. Heart rate of 92, temperature is 98.6. The patient is on a ventilator and an intraventricular, so a ventriculostomy catheter is inserted and the intracranial pressure is measured at 30. So which nursing intervention will optimize cerebral perfusion pressure? So this again is really asking the same question. We're asking about the 8s of ICP management. And one of the 8s of ICP management is to keep the head straight. Well, it doesn't say straight there, but maintaining a neutral head position is the same thing as staying straight. And so this trickery in wording is truly some of the things that is the reason why I do different wording, because Dr. Reed doesn't want you memorizing her notes and memorizing the different resources that she provides. So you can usually expect that different wording will be used that means the same thing as what you see in the notes. So maintaining a neutral head position is the same thing as saying keep the head and neck in a straight position. And of course, this allows for venous drainage. Venous drainage allows that less blood is sitting in the head, and that can help reduce the ICP. If you maintain the PaCO2 of above 35, it's not that you necessarily increase the intracranial pressure, but with an intracranial pressure of 30, you are certainly not helping to decrease it. Suctioning is going to irritate the patient and cause the ICP to go up, and of course, turning every hour is also, some of these patients are so sick that they're not even turned at all because they don't want that intracranial pressure to go up. A patient is admitted with a subarachnoid hemorrhage. In order to maximize venous return and reduce intracranial pressure, the patient should be positioned. And again, this is really referencing the 8s of ICP management, where the head should be elevated to 30 to 45 degrees. And so again, I go on and I do mention that anything between 60 and 90 degrees is going to increase intra-abdominal pressure, raising the legs way above the head, doing any of those things, bearing down when you're having a bowel movement if the individual is constipated. That's going to increase intra-abdominal pressure and therefore increase intracranial pressure. The two seem to be linked. A patient is admitted with an intracranial problem. He develops a fever of 101.3. So which of the following is of greatest concern for this patient? So the answer is D, the resultant increase in cerebral oxygen consumption. So, of course, a lot of us automatically assume that if the patient has a temperature that's elevated, that means that there is a problem with infection. And that's true. There could be. And people do die from infections that can cause sepsis. So it's an excellent concern to be worried about any patient with any kind of invasive device, which pretty much everybody in the hospital has one, that a fever indicates some form of infection. But in a patient with an intracranial problem, you have to recognize that a fever will increase the metabolic rate. So it increases the metabolic rate of the brain cell. And when the metabolic rate of any cell is increased, then that means that that cell requires a lot more oxygen to enable for the cell to work well. And when you have any kind of intracranial problem, there is a difficulty with the oxygenated blood of getting up into the head, or there can be a problem even if the ICP is not elevated. There's always a concern that you're not perfusing the brain well enough. So we really don't want those nerve cells, those brain cells, to increase their metabolic rate. We don't want their demand to be greater because we are truly fearful that we're not going to be able to meet their demand as far as oxygen delivery. So a fever in any kind of patient with an intracranial problem is not a good thing and needs to be reduced. Of course, if it's linked to infection, the physician will order antibiotics and cultures and do treat the infection, but you also have to realize that inside the brainstem is the seat of the thermoregulation. And so even if there is an intracranial problem and you haven't done anything invasive, their temperature can go up because the thermoregulation center in the brainstem is gone wackadoodle from this intracranial problem. So it's really a twofold thing. And the bottom line for you to remember after all this yapping is you don't want a fever in any patient with an intracranial problem. I hope this has been helpful. If you have any questions,